Thank you, everyone. Thanks for having us. We know we are between you and almost lunch, so very, very, very grateful that you give us our attention. And I am so honored today to introduce you to three of the most incredible founders that have crossed pathways with me since I have been starting work in health 20 years ago. But this is a bit of a different panel. So we all know healthcare is massive. We all know we have massive opportunities, but what is really, really important to recognize is we are at a pivotal point in time. If we do not seriously change our approach of how we're looking at innovating in healthcare right now, it may be really too late, because healthcare is a massive beast that is already starting to crumble, and once it starts to crumble, it goes quite quickly. And with that being said, the panel today is really focusing on shifting healthcare from big, massive, acute, late-stage sick care to early prevention, early intervention, early diagnostic. And all three founders are on the same mission, but they have a very, very different approach with how we could actually make that a reality. So, with no further ado, I want to introduce you to our three incredible founders. And first up, we have Naomi Drat from Liora Neurotech. And Naomi comes from a neuropsychiatric research background, and she also has a deep expertise in being a carer for people who are living with schizophrenia and bipolar disorder. So Liora Neurotech is on a mission to improve healthcare for people with schizophrenia and bipolar disorders. So Naomi, to kick us off, please share with us a little bit of why you are in this journey and how does it impact people.
Yeah, so is this working?
Yeah.
So the reason I'm on this journey is because I grew up as a carer for my mum who lives with schizoaffective disorder, which is a combination of schizophrenia and bipolar disorder. And that's what ultimately led me to founding Liora Neurotech to design predictive biosensing for preventing relapse and hospitalizations. And so on that note, I think I'd like to walk the audience through the patient's perspective of what acute relapse may look like. And so I'd like for everyone in the audience to imagine themselves healthy and well in this moment, but then imagine yourself slowly declining to a version of yourself that you no longer recognize, and neither does your family. And then seemingly out of nowhere, you suddenly start hearing things, seeing things, and believing things that aren't real. And they may be cruel in nature, and they also may give you acute distress, and that may place your life in danger. And so it's usually when it reaches this level of unmanageable and unsafe that it warrants hospitalization. But unfortunately, because you've lost the ability to advocate for your own health in the eyes of the law, that means that you will likely be involuntarily hospitalized, which takes place in 46% of all psychiatric admissions in the public system in Australia alone. And we know that the practice of this type of hospitalization can cause even further distress to individuals experiencing relapse. And this is because often you may be initiated on medications without your consent in moments where you may not understand what is going on, and these treatments may cause injury. And in general, the broader point is that the practice of hospitalization can perpetuate further relapses where a patient's highest risk in general is within 2 weeks to 3 months of a recent admission, and that's why it's so important to innovate solutions to break the cycle.
Absolutely. I think I was really staggered by, when you mentioned the 46% and in involuntary, and it really highlights when you walk through it from what it means for patients, but also their carers, that I guess we can all agree on that status quo is not acceptable. I think for no one that is in that system, whether it's the person living with it, whether it's their next of kin, whether it's the clinician, whether it's the system. Thank you, Naomi. Hitesh, I want to go over to you with Nutromics, because you are going into a very different direction, but it is also about hospital care, well, you can only intervene when you know how to, and picking up deteriorations earlier. I think before I hand over to you, it is really important to know that 10%, so 1 in 10 people who walk in a hospital every single day, expect something which we call incident. Incident means something goes wrong, something is unexpected. 1 in 10, that means millions of people every single year. And often they are medication errors, or they're treatment errors, or they can lead to death. So it is a massive issue, and you are on the pathway to doing something about it. So tell us a little bit more about Nutromics.
Yeah, thank you, Katja. So, I think it's important everyone understands that today's sick care system really is based off how close you are to a major medical center, how much proximity you have, how much access you have. It isn't at the point where it's a basic human right to be expected to have a healthy, fulfilling life without having routine care end up into crisis, right? Which is what happens in hospitals. And that's what we started with, right? It's a big, hairy, audacious goal that Peter, my co-founder, and I set out to solve. How do we create a world with 0 preventable deaths due to a lack of continuous diagnostics? In other words, how do we help save millions of lives? And that's great to be working on, and that was something that fueled me for a huge amount of time because of my life experiences living globally. But it was really brought home for me about 3-4 years ago when I went through my own personal health crisis. I basically went from walking my dog at 10 a.m. to being collapsed on the hospital floor by 10 p.m., being managed and recuperated by 5 doctors at that time, because I had ended up in severe septic shock and no one had realized. I basically went from the GP telling me to go to a doctor, going to one of the state-of-the-art medical centers in Melbourne, waiting for 2 hours to be triaged because I walked in looking healthy. Yeah. And then having the blood test not pick up the signs, having 2 to 3 expert doctors not pick up the signs twice of sepsis. And for those who don't know, every hour that treatment is delayed, sepsis, your chances of mortality from sepsis go up by about 8%. And 1 in 4 patients are typically not diagnosed in time. So I got lucky. I collapsed in a hospital floor in a state-of-the-art medical center with doctors around me who could manage me very quickly. And I still remember vividly, while I'm lying there on the hospital floor, embarrassed out of the hell, a doctor saying, well, we need to get some blood tests done. And another doctor saying, there's no time to get blood tests done. We just have to start broad treatment. So it really brought home why we do what we do, right? For me personally as well.
Yeah.
So that's why we're starting in the hospital. So what we're building is a wearable lab on a patch for continuous diagnostics. We've actually built this, it's a platform technology. We built this now into first-in-human studies, completed successfully. We're in hospital trials, and we're looking at a broader pipeline beyond the initial product, which is vancomycin, one of the most commonly dosed IV antibiotics in the world, to how do we scale this and actually bring human biology into the 21st century.
Yeah. Very powerful. Thank you for sharing that, Hitesh. And thank you for already giving us where your starting point is. I will come back a little bit more what actually the real opportunity is. But before doing so, from knowing early on when to intervene and how to intervene, our third founder today, who I would like to welcome, Alur Saguinsin from One Kidney, is also in that space of early intervention, but in a very different field, in kidney damage. Alur, please tell us a little bit of why you are on your mission to change lives for people who have kidney damage.
Yeah. So, as Katja said, I'm the founder of One Kidney, and I started this company because I wanted to make a better solution for people on dialysis. I'm not sure if many of you know, dialysis actually affects 1 in 10 people, and that's 850 million people worldwide. So to put that in perspective, if you filled the Sydney Opera House, you'd need 150,000 opera houses to house all of the people who are currently affected by chronic kidney disease. So if you imagine you worked your whole life, you wanted to wait till retirement, you think, this is it. But instead, you're left with having to undergo a treatment where 2 huge needles are inserted into your forearm and you have to sit still for 4 to 5 hours, waiting until your blood is drawn and filtered out through a machine until you can survive the next treatment in 2 days. So you're doing this every Monday, Wednesday, and Friday for years, hoping that you get lucky enough that you get a kidney. Now, what if you aren't one of the lucky ones? Or what if you get a kidney and your body rejects it? Well, you only have one option, and that's long-term dialysis. And I've seen firsthand how this affects people. Unfortunately, my dad got diagnosed with end-stage renal failure at the age of 62. So right when he should be enjoying his life, he was strapped to a hospital chair, tied to tubes, unable to live his life to what he could have been. And so that's the main message I want to bring home is dialysis as a solution is not a real solution, and we want to change that. And so we're planning on doing that by making an implantable artificial kidney that can do all of the filtration within your body so that people can go back to living their lives the way that they were meant to.
Fantastic. Thank you. And thank you for sharing that with us. And I think what it really highlights is that we're speaking of big system, big dollars, big opportunities, but ultimately we're speaking about people and how people are affected in the system. Not only hundreds, not only thousands, millions of people. But also we can see from the stories that all got you to start your journey as a founder that you realize there is an element of luck. Yeah, even in a great healthcare system like Australia, there's the luck that you actually have access to dialysis. Yeah, what if you're regional? That you have the luck of having a healthcare team behind you that actually talks to each other and coordinates. The luck that someone picks up a deterioration and can manage you. So what I think we all agree on is we don't no longer accept luck. We want that a predictable expectation for patients. So that is really the moment in time we want to shift together. And Alur, maybe digging a little bit deeper. So how exactly does it work? Because I was so fascinated. So give us a little bit more of how it actually works, One Kidney.
Yeah. So we are trying to replace the external machine altogether. We want to have this brand new filter made of a new material that's proven to be biocompatible, that allows people to have all of the filtration benefits of a real kidney right inside your body. So similar to the artificial heart that was tested in a real patient a few months ago, we wanted to do the same thing but for kidneys. And so that's the main core principle that we're working towards.
Amazing, fantastic. Naomi, bringing you back, what's your approach? Because you have a very novel approach on solving that problem as well. Can you share it with the audience a little bit?
Mm-hmm. So we're reframing schizophrenia and bipolar disorder as potentially being neurometabolic illnesses. And this is based on emerging evidence being pioneered by Stanford University and metabolicmind.org, which are showcasing remission of these illnesses through the use of metabolic interventions. And so it paints a future where schizophrenia and bipolar disorder can potentially be managed in many ways similar to diabetes through continuous monitoring technology and metabolic interventions. And so this sets the stage for Liora Neurotech to design and develop technologies which seek to predict and detect impending relapse as well as potentially reverse schizophrenia and bipolar.
It's really incredibly amazing because it links back to, in health we love our little keywords, yeah? We throw them around right, left and center, and we often say, acute treatment or intervention. But what you're both describing is living with, accepting that our bodies have different conditions, but we enable to live with. So I really like that approach, and I think it needs to be called out more. Hitesh, I think beyond the hospital, you have bigger plans as well. So tell us a bit more where Nutromics long-term could go.
Yeah, so I think the important thing for the audience to understand and why we talk about diagnostics, why we talk about early detection, right, is because diagnostics is foundational for healthcare. It is the infrastructure that underpins all of healthcare globally. 70% of clinical decision-making is based off some form of diagnostics. If you really want to unlock the power of AI, you need to evolve diagnostics. That's why we started with diagnostics. That's why we're starting in the hospital. But we've designed the technology to be scalable. Like our clinicians like to call it the GPS for the human body. Like that's what we've actually been told our technology enables. So we start in the hospital because it's the immediate need. It goes back to our mission. How do we help save lives? So our first product is vancomycin. It's one of the most commonly dosed IV antibiotics in the world, often given for sepsis and bacterial infections. Up to 43% of patients on that drug can end up with nephrotoxicity, complications in kidneys. Out of that, up to 33% can die from the complications. So when you think about all the stakeholders, right, for the patients, early intervention, better patient care. For the doctors and nurses, you attach a patch, you click a button, you're done. It's constantly streaming that data. It's actually not just streaming the data and giving alarm and fatigue. We're actually converting that into actionable insights for decision making that helps the clinicians save lives when they need to make a dosing decision. Yeah. Right? For the hospital administrators and the payers, well, you're not then running the higher risk of complications, which, by the way, if you end up with acute kidney injury, your cost to manage that patient goes up by about $14,000. If you're worried about that and you're underdosing, then you're keeping them in hospital for longer, which is costing $3,000 a bed, and that's a bed that somebody else can't use. With a system that's already bursting the seam, that's inefficient use of resources.
Yeah.
So we start there. We then go to sepsis management. We then start to look at cardiac management, triage. So our technology is scalable. It goes from acute, which has the highest immediate ROI, immediate impact on saving lives, to then broadening into general ward, emergency, discharge, hospital in the home, consumer health and well-being, pharma companies, and community care. Because ultimately, care is not transactional. It's a continuum of healthcare. We have to meet the patients where they are, and that means we have to be able to go upstream.
Mm-hmm. It's interesting you bring up that cost argument because we're running up against that in the health economics of dialysis, with each patient being $90,000 per year, and there's 2.5 million people. That makes it a multi-billion-dollar industry. And so to make a transplant attractive, we're having to figure out creative ways to make it feasible for payers and repayers to be able to implement our technology. I'm curious what your model would be for that.
Yeah, great question. So, there's a lot of problems to solve in healthcare, but it's the ones that people are willing to pay for that get the fastest adoption, right? So that's exactly what we tackled in the early days as well. And what we found was, well, these complications were costing the system so much that if we could reduce those complications, if we could simplify the workflow, it actually frees up more resources. There's no need for a new reimbursement pathway because there's already an existing disease reimbursement code for sepsis management that the hospitals can use. But it's definitely a challenge. Yeah. Yeah.
It's really interesting because one of the biggest, why are you not kind of like flying off the shelves and everyone wants to adopt you, which seems to be, what everyone would expect. It's the payment and incentive system hasn't caught up. As you said, where the money goes, the work goes. I think all three of them are doing the work. They deliver the solution, but it's now about the adoption. What needs to happen on the adoption side? And it's interesting because even with your technology within a hospital where you can easily connect the dots, it doesn't work. Coding is not being compared. Patient is not being in a health economic way assessed in their whole journey, but just from ward to ward to ward to ward. So there's a lot that can be done on the payer side, on really aligning the incentives to make it more attractive for technologies like all of you developing to actually be adopted. I want to take it one level higher up because we have the opportunity. What else needs to happen? Because we agreed that this is a very unique point in time. It is because Australia now is probably a safe haven, or could be considered a safe haven for international investors, for international talent, for international trials that we are attracting, and we can attract it. So the attraction is there, but how can we use that opportunity? What needs to happen to use this opportunity to actually get the tech into hospitals? Let's start with funding. Yeah, we always complain about funding, but what could be interesting, flexible ways of thinking about funding differently that you would share with the audience? And I'll start with you, Hitesh, and then we kick off.
Yeah, great question. So I think Australia is really good at the initial research and the ideas, but we as a country have been very poor at then the translation and commercialization. Founders can dream from Australia, but can you truly build deep tech products and scale from Australia? And that's what we've always believed we can do. And time again, we were told it's impossible, and time again, we've shown that we can find a way. So as an example, in the early days, it's difficult to raise early capital. We actually secured a $2.5 million grant from the Federal Department of Industry Innovation, a CRCP grant, which actually gave us a huge kickstart. We could leverage the R&D tax benefits, we could leverage the grant. So when we went to the investors, what we were telling them is that, well, financially, for every dollar you invest in us, we have $3 of non-dilutive capital already secured. And we've actually helped other founders to also do the same model and secure that early kickstart into their companies as well. We've built that collaboration and ecosystem now with UNSW, with Uni of Sydney, with Westmead, with Monash, with so many international partners as well, which help pave the way. And we try and make that available to founders who are coming behind us and the broader ecosystem. One of the pain points we faced was clinical trials. Australia is well known for clinical trials and research, but it's normally tackled and aimed at big pharma companies. And it is very expensive for a startup to run clinical trials. So we faced that problem ourselves. We were lucky we had the right backers and investment, so we solved for that. But then we actually looked at, well, why can't this be simpler? So we actually applied to the NMHRC, and we have the second private provider of HREC services in the country. There's over 280 odd public HREC providers affiliated with Australian hospitals, but there's only Bellbury and then us. And we've actually set it up specifically for wearables, for diagnostics, for the startup ecosystem. We've been getting that model right, we've been using it ourselves, and we've been able to bring our clinical research program from a lead time of 6 months to 9 months down to weeks, and cut the cost by over 1/3. So we're building that playbook, and now we're making that available to others in the ecosystem as well.
I think that deserves a round of applause, because that is truly giving back to the ecosystem. And for those of you who usually are not dabbling in health so much, so HREC is the human ethics process. It's a very cumbersome process. It is there for a reason, but it can be very lengthy and very costly.
But it can be innovated, and it can be done safely. Yeah. Patient care and patient safety is always front of mind.
Yeah. Amazing. So the last 2 minutes before we kick off, I just want to really come back to the point that we all agree we need to get serious about it right now to invest in prevention, early intervention, and diagnostic. I think it's the point in time. Investment dollars cannot go only into the late stage assets. They have to go upstream. We really would love to have those conversations with the room here. The second thing is, there is a moment in time where we have an opportunity to be a bit more creative and flexible of how we combine dollars in this country to help our founders. And that is another conversation we would love to see happening when you actually meet our founders over lunch. And thirdly, it is about being a believer, not only because it's great tech, but because it actually makes a real impact on the lives of thousands of people. And hopefully a lot of you can understand a little bit more what it means, really, what it feels like when you would make that impact. So with that being said, I would love to, what are the conversations you specifically would love to have with the room? And we might just start off with Alur and go down the road.
Yeah, I guess my main vision for my company and the world in general is that no person ever has to do dialysis ever again. It seems archaic. It's kind of like the iron lung when they used to treat polio. So I want to make partnerships with people who can give patient capital. And I mean that in both senses of the word. Patient in terms of people first, but also patient in terms of the long runway it takes to bring any med tech product to market. And so if that's something you can help with, or you know anyone who's affected by kidney disease and can help in this space, I'd love to have a chat later. But yeah.
Should be more than 50, 1 in 10. Yeah?
Yeah.
So someone in you might have a silent killer sitting in them. So, Naomi.
So Australia has a national priority to invest into community-based mental health services, and with a solution that we're proposing that can potentially enable that to become a reality. And so I'd love to connect with people in the audience who can connect us as stakeholders and decision makers to potentially collaborate with us on the initial pilot study to design that technology.
Fantastic. So it's about the first believers. Yeah, fantastic. And Hitesh?
Yeah, I think it really starts with a conversation and collaboration, public-private partnerships, and how do we look at match funding or incentives like that between government and venture capital. How do we collaborate amongst founders in the ecosystem as well? We've talked a little bit about that offline as well. And I think the key message here, I suppose, is it's not a question of if healthcare will change or when healthcare will change. Healthcare is changing now. We are making that change now. And now the questions become, how big is the disruption going to be? So if you're interested in being part of that story, if you're interested in being on that journey, be it an investment angle, be it how do we set up manufacturing and create products here, be it how do we collaborate in the ecosystem, reach out, and we're open to that conversation.
Fantastic. Thank you very much. Incredible for sharing your perspectives today with the room. And let's give a big round of applause.